I'm James Reed, I'm a CCIO. Well, I'm in the habit of saying by day I'm a forensic psychiatrist, and by night I'm the CCIO, because I just feel like that quite a lot of the time. Unfortunately, I'm yet to don the Batman costume. So to say a little bit, first of all, how many people here are from mental health trust background settings? Oh, okay, fine. So I've got a few familiar faces. So basically, in a nutshell, I mean, I'm not going to say a lot about our organisation. We are a large-ish mental health trust. I mean, there's a bit of debate about who's the largest mental health trust and whether it's a mental health and community or whatever. But we are a large-ish mental health trust. We do sort of a mixture of specialist and general services. You know, we do community mental health, we do psychology services, we do forensic psychiatry, what I do, and so on. And importantly, we do a mixture of both inpatient and community work. We are one of the mental health GDEs, and we're doing all sorts of things. I'd like to say that we had a grand plan and a real a big vision. I'm not sure it's quite like that, but we certainly are investing in quite a lot of different projects of different sorts. So I'm going to try and introduce this area. Now this is Solihull Hospital, for any of you know Birmingham, which is in sort of the south of the city, on what was then known as the psychiatric Riviera, which took into account both this and another very large psychiatric hospital down the road. Now, this is where psychiatric care used to take place, and for one reason or another, and for better or for worse, as you'll be aware, the vast, if not all of these sorts of hospitals have now gone. So, I mean, at the formation of the NHS, a very large proportion of inpatient beds in the NHS were in psychiatric hospitals. And I think in Birmingham on its own, we had about 4,000 beds, of which, a good few thousand were here. So this is, I think, what most people's idea of what psychiatric care used to be is like, which I think is fair enough. And of course, where psychiatric care takes place now, I mean, most of you will have heard of care in the community as a bit of either a sort of a buzzword, sometimes it's seen as a bit of a byword even. But nonetheless, the feeling generally is that mental health care takes place in the community, whatever that means exactly. And so a lot of it, that does mean in people's homes like this or in outpatient clinics and so on. But I think there's a bit of a misconception that, because mental health is often bracketed with community, as in community trusts, and there's a perception, I think, that really all mental health care is pretty much the same as community care, and that's about it. And the feeling is that sort of the inpatient era is over. But of course it isn't. This is a picture of the Tamarind Centre. This is where I work. So this is a relatively, it's about 5 years old now, quite a modern NHS inpatient psychiatric hospital. It's actually a medium secure unit. But the point is, it is a reasonably large psychiatric hospital. And in Birmingham, this is one of our other inpatient units. And we have quite a few. And so all in, I think we've got about 300 and odd beds. So most mental health trusts do, as well as doing a lot of community work, do inpatient work as well. And I think that's often sort of missed. When you think about inpatients, you think about acute hospitals, but I think it's often forgotten that actually psychiatric hospitals do quite a lot of this sort of work. And whereas I know there's a lot of debate, I think, about to what extent we need psychiatric hospitals, how many beds we need. I think most psychiatrists would say that we need more beds than we've got. We've probably gone from a situation where we had rather too many to a situation now where we've probably got rather too few. But the parallels of acute medicine are exactly the same, in that most patients are seen in the community and clinic, but now and again there's a deterioration and they need to be admitted. And it's exactly the same for us. So because of this, I think when you think about particularly the use of systems, and you think about the systems that are out there and any kind of technology, a lot of it, when it's mental health is talked about, is focusing on community. As that might be systems for improving community appointments, it might be things to do with outpatient clinics, it might be to do with, for example, maintaining staff safety and all this sort of stuff. And that's all absolutely fine. But I think there is a need to look at the work we're doing in our inpatient wards as well and apply a similar degree of work to that. I think in general, as far as acute hospitals are concerned, a lot of the developments have gone and have focused on the inpatient side. And there's a lot of apps and things for doing vital signs monitoring, a lot of things for improving the way wards work and electronic whiteboards and everything else. Perhaps less so on the community side. And certainly as far as mental health is concerned, it's the other way around. Most of the developments have been on community and little attention has been paid to inpatients. So this is a real roundabout way of getting to the subject, but the point, what we wanted to do, and again, I would from the outset, I'm not a human factors expert by any means, and I would love to say that we sort of had all these ideas and principles in mind when we've begun this work. It's not quite like that, although the way we've actually worked out, I think we've ended up applying a lot of the same sort of approaches, and certainly things we've learned in doing this kind of work will apply elsewhere. So what we set out to do was to sort of define what we think the digital psychiatric hospital, the digital psychiatric ward actually looks like. So it's a deliberate attempt to provide solutions and things that work for our inpatient doctors and nurses. Now, of course, the setting, this is fairly obvious, is entirely different. I mean, much like a general hospital, inpatient wards are relatively acute. There's lots of real-time tasks going on. There's lots of things happening that need to be done immediately, whereas community work tends to be less intense like that. So you have a different sort of sets of problems, different challenges, and I think the solutions that have been developed out there for working in acute hospitals in general, and this is a generalisation, I know people are trying to do some of this sort of work, would not necessarily translate directly to a psychiatric inpatient unit either. So the particular one I'm going to talk about is therapeutic observations. So therapeutic observations are a particular mental health thing. I don't think there's really a parallel elsewhere. So whereas in a general hospital, patients will have their blood pressure and so on checked at regular intervals, whereas we need to do that as well, we also have a concept of observing the patient. So every patient in any psychiatric hospital will have an observation regime. And that will vary. I mean, again, this is one of these things that nationwide differs enormously between trusts. But broadly speaking, there'll be an concept that the patients will be seen or intentionally observed by a nurse or a healthcare assistant at an interval of time. And that usually is no less than every hour. I mean, it varies a bit, and some places take a different approach. Certainly for our wards, it's no less than every hour. It could be as much as every 5 minutes. Obviously, it could be as much as continuous observations. And indeed, it could be continuous observations with 1, 2, 3, 4, 5, or 6, or more members of staff as well. And I do remember early on seeing a patient who was on a sort of a constant 6-to-1 observation. Now, that's unusual, I have to say, but it does still happen. And the design of this process, of how it's done most places, hasn't changed for probably hundreds of years, whereby you have a member of staff whose job it is to have a clipboard with a list of the patients on and a grid and their observation intervals, and their job is to go around looking at them and scribbling in the box to say they've been seen. And it's no more sophisticated than that. Now that's obviously, in terms of if you were designing a means of doing this, it's a problematic way of doing it. First of all, it's difficult to know which patient is on which level of observations at any given moment. And that can be done usually by checking on the whiteboard or asking around even, or looking at the observations list, which again has to be up to date. And if somebody decides to change an observation level somewhere, particularly if it's a meeting off the ward, that has to take time to propagate back. So knowing exactly what the current levels are is difficult. And then just practically, especially with some of the closer levels, like 5 minutes is a relatively short time to actually do the observation, then do something else, and then come back and do another one again. And keeping on top of that is actually quite hard. And then, of course, simultaneously tracking, say your 15 ward patients, which one has had their observation done when, and when their next one is due, is a pretty much impossible task, actually. And yet, this is what happens. And so you'd have at least one member of staff with a clipboard wandering around the ward, trying to keep on top of the observations. Now, that's difficult to do for a start. The other problem in terms of sort of safety and quality is that there's a lack of accountability there. I mean, what you end up with, generally speaking, is a squiggle in a box. And trying to work out who was meant to be doing the obs at any given moment, particularly if you're looking back, is almost impossible. Quite commonly, the job that would be given to often more junior staff on the ward, often if you have temporary staff in, they might get given the job to do. And so particularly when there's been a problem, trying to understand who was doing it, who was responsible, and who signed is very hard, actually. And associated with that, there's often a lot of errors, and of course, like someone said earlier, these sorts of errors most of the time don't matter, because with an observation, once it's happened and the patient's been seen, it probably then doesn't matter. It matters when something's gone wrong and when there's an incident, and that's when everyone looks back. So as a result, when you do look back, when there's been a problem, you'll often find all sorts of mistakes that the levels weren't known correctly, or it wasn't done at the right time. And the other thing, I'm sorry to say, is you do encounter a lot of poor practice, and you do encounter falsification. I mean, certainly in our trust over the years, we've had incidents where patients have died in the night, and when the observation charts have been examined, it's been filled in nice and neatly all the way through to the following morning, and the patient's been observed every 10 minutes all through the night, even though they died some point in the course of the night, for example. We've also, and this is, I'd like to say, and I think it is uncommon, but it happens, and of course you only find out when there's been an incident, and you can be fairly confident there's been lots of occasions when it's happened and nothing's gone wrong and nobody's found out. So all in all, it's a major problem, and the first, whenever anything goes wrong, particularly with deaths in hospitals, these are a big deal for us, particularly if there's been a suicide. the first thing everyone does is go back and look at the observation records to see who saw the patient when and what happened. The other thing, of course, to add to this is that what you get is simply a record they've been seen. You don't get anything other than that. And you'll get a signature in a box, but you won't get any kind of understanding of what the patient was doing or anything about it. And the end result is this, an awful lot of paper. So if you can imagine a patient perhaps in one of our hospitals who's been admitted for a year and has been on, say, 15-minute observations for a year, that means they've got they've got a piece of paper with a tick in a box every 15 minutes, every hour, of every day, of every week, of every month for a year. And if you multiply that up by 307 odd patients, that turns into a huge amount of paper. And now the vast majority of our filing consists of these observation records. We've cut almost everything else out, but we've got warehouses, a bit like this, full to the brim with them. And they're really of no actual value because there's nothing to be gained from going back a year and looking at a patient's observation sheets from a year ago. It doesn't tell you anything, but yet they're part of the record and we have to hang on to them. So, the way we kind of approached this was a bit like we've heard away, was to start to analyse the task, because everyone, if you talk about observations, people broadly know what you mean. But we had to sort of actually analyse it in quite some detail about what we actually meant. So, this just sort of shows, so the observation is the thing at the centre, but it starts with a who it is, who is it you're observing, then why are you doing it, when are you doing it, what exactly you're meant to be doing, who's doing it, where it's been done, when it's been done, and what you saw. So a simple thing that at the moment is a squiggle in a box actually breaks down into quite a number of tasks, and there's quite a lot of information associated with that. So this is where we began. And then the next thing to do was to work out what we're going to do about it. Now, it's fair to say that nobody out there has done this in terms of products. So we've talked a lot about suppliers, and I have to say we have very similar problems with suppliers of various of our systems. In this particular case, though, there really wasn't a system to buy. So we did take the view that we, as the saying goes, have the technology and this is something we're going to do ourselves. Now we've got developers in-house and we've done bits of work. We've never really tried to build effectively our own clinical application before. We were confident that we had the capability to do it, but it was also an opportunity to try and do things a bit differently and actually involve people and design something from the outset that would work, rather than trying to make the best of something that we'd bought. And I'm pleased to say it didn't cost $6 million as well, actually, which might have been more of a problem. We've got Rio. Rio's our electronic record. It's one of probably the two main mental health systems. And the first thing we wanted to do was to make life as easy as possible, because what we didn't want to do was bring in a system whereby you had our Rio, which does most of the work, and then some new observation system whereby all the patients had to be kind of re-registered and re-input, because if you had a thing like that, you could see that one of the two tasks would get done and the other one wouldn't. So they might get registered on Rio, but they wouldn't end up on the ward device, or the other way around. Or you can certainly imagine a situation where the patient's lists were out of date and so on. Thank you. So we decided to pull as much of it through from Rio as possible. And that meant, in terms of a forcing factor, I think, that it forced the staff to correctly register the patient on the wards, because up until now, they should have been registered on the ward, and often they weren't. So this is very briefly what it looks like in real life. There's a phone-based app where the staff record all sorts of things, not just that they've seen them, but where they've seen them, what happened, and so on. And they get a nice list which shows them with times and countdowns who all their patients are, when the observation is due, and so on. And they can also see other stuff like the patient's photo, which actually, surprisingly, especially when you have temporary staff on a ward, they don't necessarily know who the patients are. And so having the photo there means that in your hand you can see who you're meant to be observing, the care plan, so why, when it's all meant to be done, and you've got easy access to recording it. So we got our nurses involved in this right from the start. We had a lot of input from them because they're the people who are going to use it, obviously. We had to make it as easy as possible to do. And it was also about improving the quality of the task. So we did a lot of this kind of prototyping and testing. So we did the work initially. We put it on one ward for one day to start with, just to see if it would actually work at all. And then when that worked, we took a break, refined the design a bit, did it on the same ward for a week, stopped again, and then went to the same ward for initially a month, and then that carried on. And it's one of the few occasions that I can remember where we actually had the staff asking to have it back when we took it off them, which I thought was a very good sign. And these are some more screenshots of it. The other good thing about this is it feeds these more general boards, so the ward manager can see who's on what observations and when they're all due. And this is a kind of broader sort of speaking timeline view as well. And this does also offer us the opportunity at least to start making some use of this data, because all of a sudden we've got some kind of record of what's been going on in a ward, and the idea would be over time to start using some mathematical modelling on this to actually predict areas of demand and so on. And we also do some physical obs work. This is my secret YouTube demo. I mean, it's in the slides. It's a bit of an old one now, but if anyone's interested, it does actually I sort of show you how it all works. So we've got it on all of our wards now. It's on a mixture of phones and tablets. Technically, it's been a great success, actually, it works. And I think we've certainly got at least 1 million individual observation events now recorded. The challenge is, just to finish off, the technology predictably is the easy bit. Some infrastructure, Wi-Fi problems, but nothing to worry about. The UI has broadly been, the main thing we had, which was interesting, was we started with a red, amber, green thing, and the staff didn't like that because it felt a bit sort of accusatory. So I think we've changed it to a sort of purple or something else, with not red, amber and green, which was interesting, and we hadn't really thought of that. And through the feedback from what the ward staff have been saying, we've made some little tweaks and changes here and there. The interesting sort of challenge, I think, has been in terms of adoption, has been actually people choosing to use it or not, and finding quite creative ways of not using it. So, for example, a few of them staff discovered that if you put the wrong password on the phone in 10 times, then it locks the phone out and you can't use it. So we said, this system doesn't work, these phones aren't working. And of course, the audit logs show they put the wrong password in 10 times. And sometimes, for example, we train the first shift with the basics with the idea they cascaded it to saying go to the next shift, and then it just didn't happen. So most of the problems have been actually getting people to use it to begin with and getting over the understanding of it being a change. Once they're in and using it, it's been much better. And this is the other thing which interested me, is that people were worried about the motivation for doing this. I mean, my view always was this is to help the staff to make their jobs easier. But some staff certainly seemed to believe this was done as a means of beating them about the head. And to the point that I heard from a member of staff that they believed that if somebody missed an observation, some kind of siren went off in the trust headquarters and a squad car came out to cart them off and hang them up before the NMC, which is amazing, really. So that was one of the biggest things we had to kind of to say, no, really, honestly, we're trying to help you with this. We're not trying to cause a load of trouble. There are some issues around willingness to change, clearly, and familiarity with technology is a bit of a cliche, but there is a generational aspect to this that we're working on, and we've got further developments due. So then, in a nutshell, this is a big change to existing practice. Like a lot of things haven't changed for many decades, if not centuries. But there are clear benefits to patient safety, and I think we've had both. I think certainly the successes we've had have been by using this kind of human factors approach, even without perhaps realising that's what we're doing, in terms of involving people from the start, iterating the design, and producing something which genuinely makes their life easier and their work better. But similarly, there are some challenges at a human level that we've got to contend with as well.